Good morning, Dr. Bevan. Can you hear me?
Yes, I certainly can.
And you can see me, can you?
I can.
Oh, good morning. Just before we start, I have a few words to say to others who are listening. So excuse me for a moment.
Of course.
The people I'm speaking to now are the 100 or so, maybe more, who are listening remotely to what I have to say. This is our first day of hearings in the new year. Already in 2021, COVID has affected our plans, as it has affected the plans of so many others. It is important to make progress with the hearings, but it is vital to stay safe. The way those two considerations fit together means that we cannot do things as we would have wished. When I last spoke to you, early before Christmas, I had hoped we might be able to hear more evidence in person in 2021. All our witnesses this week would have wished to be here in person. Participants in the inquiry who wished to do so would have been able to come to Fleetbank House. Unfortunately, this is not to be. You will, I trust, understand why. Why in these days of the new lockdown, this is the price of our making progress. Safety, yours, ours, and mine, requires it. You are, of course, listening remotely to me as I say this. It goes without saying that we will continue with the live broadcast, YouTube, and update meetings for inquiry participants. I trust you will understand there may have to be further changes to the timetable until the siege imposed by COVID is lifted. But I can assure you that though more witnesses will be obliged to give evidence remotely, just as this week's witnesses will, the inquiry's approach will be just as thorough as if witnesses were with us here in the hearing room. Now, Dr. Bevan, you're at home, are you?
I am, yes.
And you're on your own, I think?
I think my daughter is somewhere in the house, but essentially on my own.
We here, so I can tell you what you're looking at. You're only seeing part of it. You're seeing me, I think, at the moment. In
Yes.
the hearing room, there are 3 members of Council's team, socially distanced to the extent of being almost remote from each other, across the room from me. There are 3 members of the inquiry staff in the room at the far corners of it. It's a room capable of holding 200. It holds, at the moment, less than 10. One of those members of staff, Mary, will ask you to take the oath in a moment or two. And we have Shumik, whose job it is to make sure that if documents are referred to, you can see them, and so can those who are following remotely. You are talking not only to us here in the room, Dr. Bevan, but you're talking to everyone out there who is watching remotely. The number varies from time to time, understandably, but it will be, as I've said, in the 100 or so, maybe more, people who are keen to hear what you have to say. Well, with that introduction, Mary, may we ask Dr. Bevan to take the oath, please.
Please state your full name.
David Hugh Bevan.
And repeat after me. I do solemnly, sincerely.
I do solemnly and sincerely.
And truly declare and affirm.
And truly declare and affirm.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
and nothing but the truth.
I left my book, my notebook. It's in my bag, which is sitting beside the desk. Yes.
Dr. Bevan, good morning. Can you see and hear me?
I can. Good morning.
I'm going to start just by asking you to provide us with an outline of your career. As I understand it from your witness statement, you had various general junior medical posts in the mid-70s, 1973 to 1976.
I did, yes.
And
Mostly
then,
in the North of England.
And then you took up a senior house officer post in medical oncology at the Royal Marsden Hospital from late 76 into May of 77.
That's it. Yes, that's right.
And then from July of 1977 to December of 1978, you were a registrar in haematology at St George's Hospital.
Yes, and the rotation around local hospitals, which was the training regime there.
And was this the beginning of your career in haematology?
It was.
You've described in your statement this being this first period, the 18 months or so from mid-77 to late 78, as being a rapid introductory period for the novel cohort of trainees who'd no prior experience of laboratory work and who were recruited for their acute medical experience and MRCP in order to care for patients with blood diseases. Could you just outline a little what you meant by that?
Okay, hitherto, haematology had been very much a laboratory speciality and part of the clinical pathology orbit in the NHS. And so the trainees who ended up in haematology had usually commenced by doing, soon after registration, by doing a rota of jobs in the various aspects of pathology. So they would do some time in histopathology, and autopsy work. They'd do some time in bacteriology, microbiology, and they'd do hematology and also chemical pathology. So there was a rotation through the various laboratory disciplines in clinical pathology, and then they would choose which one of those disciplines they would specialize in, end up in, and then hematologists would come from that arena. Hematologists began to realize that people with blood diseases, who at that time were clinically under the care of general physicians, some of whom supposedly were said to have an interest in hematology, some of which had no real interest in hematology. And the college's joint committee between the College of Pathologists and the College of Physicians came to the conclusion that hematologists, where possible, should look after their own patients clinically, and that therefore they needed to recruit a new cohort of individuals into the subject who had general medical experience and therefore and the membership of the Royal College of Physicians, and therefore would have a decent basis to enter such a profession as a clinical hematologist in the NHS. And basically, from then on, that became the approved mechanism for generating consultant hematologists.
And in that first 18 months or so, before your appointment as a senior registrar at the end of 1978, you described you spent your time, first of all, learning laboratory work without any haemophilia contact, and then laboratory work for the purposes of haemophilia. Is that broadly correct?
Yes, they obviously had to give us a crash course in the laboratory aspects of the subject. So, for example, absolutely typical of a consultant hematologist is looking down a microscope at blood cells and deciding whether someone has a leukemia or another blood disease. So we had to be taught from scratch how to do that. In addition, we had to be taught about the semi-automated and automated machinery in the laboratory, the methods of quality control, and eventually also that of the coagulation laboratory and its special tests. And there was a kind of internal rotation that accomplished this as well as possible.
And then in
So
December
that's
of...
the main,
I'm
sorry.
sorry, carry on.
The other aspect was it was at that time on-call work in laboratory overnight and at weekends was shared between professional technical staff who were able to do it with great expertise and hematologists and other pathologists in training as a kind of baptism of fire, having to cross-match, blood for people in life-threatening emergencies when one's experience and knowledge and technical skills was simply not up to it. So that was, I think, a period of considerable error. But I remember doing that, and while doing that, one was also on call for the Hemophilia patients of the unit, who used to gain entrance for treatment by battering on an outside door of the laboratory, which in that time was in a series of sheds, basically, to get in and to be administered usually cryoprecipitate. I could manage that, but my skills as a laboratory technician were minimal. I'm very glad to say that whole system was abandoned very soon afterwards, and on-call work was then done entirely by fully trained technical staff.
Now, December 1978, you were appointed as lecturer and honorary senior registrar in haematology at St George's Hospital Medical School. And that was an appointment that you fulfilled from December 78 until 1984. Is that correct?
Yes, yes, that's correct. It was a lecturer job. Technically, it was a lecturership with the St George's Hospital Medical School at an honorary senior honorary senior registrar role with the hospital. In fact, it was almost entirely a service job. At that stage, there was hardly any lecturing or teaching duties to do. One assisted at practical teaching, but the lecture was a way to find the funding from a different source, basically.
And you've said during this period of 5 years or so, it was part of the South West Thames Senior Registrar Training Rotation, and you worked in a number of different hospitals and locations over that period of time.
Yes, that was the official training rotation of the South West Thames region, which was held with St George's as the teaching hospital base, and then a number of other hospitals where one gained experience of specialist hematology. So part of it was spent at St George's, but an equal part, a year I think, was spent in a district general hospital. At that time, I was at St James's Hospital, Bevan, which was very close to St George's, but was a separate institution at that time. And then the specialised training was at the Royal Marsden Hospital in hemato-oncology, because at that time it was, and I think has always been the case, the majority of people training in hematology went on into what's called hemato-oncology, treatment of leukemia, lymphoma, myeloma. And so there was a considerable time spent at the Royal Marsden Hospital. And then also one had formal attachments to the National Blood Transfusion Service at Tooting. So that was the rotation. So for most of that time, I was outside St George's. But when I was in St George's, obviously that was when I began to learn a bit more about the patients with haemophilia.
And throughout that period, Professor Flute, and I'll come back to him in a few minutes, but Professor Flute was the consultant haematologist and the centre director for the purposes of the St George's Haemophilia Centre.
Yes, he was a professor of haematology at the medical school, honorary consultant haematologist and Haemophilia Centre director.
And in the course of this period, you took your MRC path exam.
Yes, at the end. I mean, the whole rotation was geared towards equipping someone to be able to take that exam and hopefully pass it. And that was done then towards the end in 1983, in I think the autumn of 1983.
You've observed, sorry.
It's okay. That's it.
You've observed in your statement that the two parts of that exam that were most frequently failed at that time were the practical exams in coagulation and blood transfusion. You didn't fail, you passed. But do you have any understanding?
Yes.
Do you have any understanding as to why those two areas were the most frequently failed?
Well, they were wet practicals. This was abandoned several years afterwards, but at that time, one was expected to actually do a practical examination where one chose the tests one was going to do and carried them out on the bench on blood and plasma and other substances, and then one analysed the results oneself and came to a conclusion. And once again, because we were not fundamentally trained in laboratory hematology, the wet practical part could go badly wrong. And I remember at Oxford, at one stage during my blood transfusion practicals, I was faced with a water bath with all the tubes floating upside down in it. It was the other thing that happened in the coagulation practical, which has a strange bearing on it, was that the sample tubes with standard preparations of blood factors in them would go off during the actual hour or two of the practical. So you'd end up with something that had much less of substance X in it than there was at the beginning. So the practical was a lottery. And at some centres, all the candidates would fail. They were notorious for this. Thankfully, I went to Oxford, which was one of the more civilised centres, as one would hope, and managed to get through. But it was an ordeal, and I was very glad I never had to sit it twice.
Now, in 1984, having successfully passed the MRC Path exam, you were appointed Senior Lecturer and Honorary Consultant in Haematology at St George's. And you remained in that post from 1984 until, well, in reality, I think until 2008, although the titles and the contractual arrangements changed in 2004.
Yeah. Yes.
Initially, Professor Flute remained the Centre Director and Head of Department, but he took early retirement sometime in 1985. Can you recall when?
Sorry, what do you want me to?
When Professor Flute took early retirement?
Yes, that was in 85. Up until then, St George's was more than just St George's still. The consultant staff were responsible for running the laboratory at St James's. I think my first year as a consultant was spent mainly there, because the sitting consultant there had gone off with severe health reasons. And it was a bit of a surprise to the other two consultants in the department, because by losing that colleague through ill health, there were just the three of us, Professor Flute, Dr. John Parker Williams, and myself. And it came as somewhat of a shock that Peter Flute left quite suddenly to become, he didn't actually retire at that point, he became Southwest Thames postgraduate dean. So he moved into a part-time training and academic role outside St George's. And it basically left the entire menu of haematology at St George's to be run by myself and Dr. John Parker Williams. And among my half of the responsibility, for I took most of the responsibility for the clinical side of the operation, because John was excellent at the laboratory side. Hemophilia became a part of it. And by becoming the consultant responsible for haemophilia, one sort of automatically became the centre director in relation to the UK CDO and the national system.
And that was in the summer of 1985?
July, yeah.
Now, just following through your career before we come back to look at St George's in more detail, you've described in your statement how in 1987 a professor of haematology, Professor Gordon Smith, was appointed at St George's, and that brought with it in due course more funding, which allowed the employment of more staff or appointment of more staff, including for the first time a haemophilia nurse.
Yes, I think that was in the very early 90s that we managed to get our first haemophilia nurse. And from then on, we were allowed to, as the funding became more channeled from via the Pan-Thames Haemophilia Consortium, which was a specialised commissioning group as part of NHS London. things were put on a much better basis in that our needs, if we made a good case that we needed, say, a second nurse or pediatric nurse, or we needed a centre organiser, administrator, then funding was released from the Pan Thames Haemophilia Consortium to cover that. So yes, so the appointment of Ted Gordon-Smith completely transformed the department from something that was becoming an extreme backwater, understaffed, into a major centre. So.
And then in 2008, you moved to St Thomas's Hospital as consultant haematologist and the Haemophilia Centre Director at the Guy's and St Thomas's NHS Trust.
Yes, I did. I mean, I had at the beginning, I'd done everything, including leukemic treatment and so on at St George's. And then as we appointed new, younger consultants, most of them had a hemato-oncological bent. And so I moved out of that area, and my patient base it still remained multidisciplinary, but it became restricted mainly to haemophilia, bleeding disorders and thrombotic disorders, and sickle cell disease and other hemoglobinopathies. So I had to think very carefully before leaving my sickle cell practice, but I worked on the basis that new blood was needed to look after that part of things, and that things I'd wanted to do in terms of, I wanted to accomplish something in the research line in one of the subjects I did, and this only seemed to be able to be facilitated through going into this very specialized role as a Haemophilia Centre Director. And of course, because throughout one's tenure as a haemophilia doctor at St George's, the centre at St Thomas's, Guy's and St Thomas's Hospital had been, in very large in our lives, and it was a considerable challenge to go and take over that centre. So, but luckily they suggested it to me, so eventually I decided to go there. And in fact, it did turn out that way with the research, that I was able to participate in proper research there.
And you remained as director until 2016, when you relinquished your director role to Dr. Dolan. But you remained a consultant full-time and then part-time until March 2018, when you were retired. But then you came back as a locum consultant, I think, until March 2019.
Yes, I was one of the senior consultants that was in a position of possibly being caught in a retirement trap. So one took retirement when it was available, on the understanding one would retire and return to work, first of all in a general capacity to support Dr. Dolan during his initial years, and then as I said, as a tragedy which affected a close colleague at St Thomas's unexpectedly, I was called back from retirement to help out for a further year. So my retirement was somewhat delayed, but eventually happened.
And throughout the period from 1985 to your eventual retirement in 2019, you were a member of UKHCDO.
Yes.
And we'll come back to UKHCDO in a little more detail later, but you were not, for the most part and for most of that time, involved with its working parties or its committees?
Not at all. I think the haemophilia directors of smaller centres, we were a kind of medium-sized centre. As Mark Winter's study showed, in the south of England, there were haemophilia centres with directors who attended regular meetings who had no actual patients, or very few, or mild patients only. But we did have a substantial number at St George's. Nonetheless, at UKHCDO, the roles on special working parties and their special committees were reserved for major centre directors, so-called reference centre directors, and later comprehensive care centre directors. I mean, no doubt if I had specifically asked or to be included on such a working party, I would have been. But because of haemophilia was still only, I would say, even at the height of involvement, about 10% of my workload at St George's. I never quite had the time to devote to such working parties. Yeah.
Now, if I can turn to the physical facilities of the Haemophilia Centre at St George's, when you first arrived there and over the following few years through into the mid and late 80s, what was the centre? What physically did it comprise?
When I joined, the haematology department of St George's in Tooting was accommodated within, and in fact the entire haematology laboratories were accommodated within a strange improvised structure between several of the Victorian hospital blocks, with wooden walls and ceiling, which was a bit like a rabbit warren. And then at one stage it had an external door, and inside that external door was a series of little clinical rooms which were used for every conceivable purpose for patients. And the haemophilia patients came in and were treated in one of those rooms where there was a bedstead and a chair where intravenous therapy could be administered and people could be examined. There was no specific haemophilia office or centre in the way in which anybody understood it. What that might mean, a specific clinical space devoted entirely to haemophilia and with special facilities for children and so on, was simply not there. And then there was the laboratory, and all the treatment product was stored in refrigerators and freezers in the haemophilia laboratory. And the telephones that patients accessed were in the haemophilia laboratory, or the hemostasis laboratory, blood clotting laboratory. So it didn't fulfill any of the definitions which centres were supposed to fulfill. So that's about it.
Did you get the sense that laboratory facilities were prioritised over clinical facilities for any available funding?
I think we made various efforts to establish a clinical haemophilia centre somewhere in the building. That jerry-built haematology complex was itself left within my period of time as a senior registrar and re-established within the medical school block in a kind of large functional hangar-like space, absolutely fine for a laboratory, but not very suitable for a clinical facility, since it was actually removed from the clinical facilities of the hospital, and it would be different. You would have to set up your own kind of crash trolley and emergency system there. So we kept appealing for a proper clinical space, and the hospital never decided that it was one of its priorities. Instead, of course, our patients were treated in an increasingly sophisticated day unit, but they shared that day unit with all other haematology patients. But the day unit was well-equipped, well-staffed, and safe. And the children used to go to the Pinckney Children's Ward, which already ran a kind of outpatient for children. So that in that way, it complied with the preferred model for children, which was it was in the paediatric part of the hospital. So things worked, but we never had that single haemophilia centre where all the patients knew they could go.
Now, in terms of the numbers of patients, we'll look at a couple of annual returns in a moment, but your recollection in your statement was that there were, in late 70s, early 80s, there were around 25 severely affected patients, Haemophilia
Yes.
A and B, including approximately 8 children, and that those numbers increased over the years that you were at St George's until about 30, the number was in the region of about 35.
Yes, one was fairly sensitive to these numbers because certainly during my time as consultant, the UK HCDO was looking at definitions of various grades of centre, and they were looking at a definition for a comprehensive care centre. And for one reason or another, they settled on the number of 40 severely affected patients treated in a year on a consistent basis. And one was always aware that one was just underneath that. I mean, sometimes one might have had 40 severes, but they weren't all treated within a year. Others, the numbers just came slightly under. So we never quite reached that 40 patient mark. But I remember at the end, we were certainly very, very close to it.
And in that period, late 70s, first half of the 80s, do you have any recollection as to how many patients not severely affected, but mild or moderate, were patients of the centre?
This is where I'm afraid my memory begins to fail me, and the fact that being retired, I have no access to any kind of electronic database. But I see, by definition, it's normally assumed that a certain number of severely affected haemophilia patients were accompanied by a slightly greater number of moderately affected and a very great number of mild. In fact, it's not like that at all with haemophilia. Moderate haemophilia is perhaps slightly rarer. So, and the mild haemophilia group is a somewhat amorphous. It changes from time to time. So my feeling would be there would be about another 50 or so in those two categories, mild and moderate. And then, of course, one was responsible for a considerable number of people with von Willebrand's disease and other bleeding disorders. And von Willebrand's disease was about equivalent to the number of severe hemophiliacs. But that, again, definitions change. So mild von Willebrand's disease, you might be looking at 100, up to 100 people with von Willebrand's disease who were attached to the centre. And a lot of the kind of clinic work, outpatient clinics, involved seeing people on a routine basis with mild bleeding disorders and looking after them then when perhaps they needed surgical operations and so on. So you had to be always ready for that. But in surgery, the adage is that there's no such thing as a mild bleeding disorder if they're having surgery. Take it all seriously.
Now, just wanted to come back to your relationship with St Thomas's, which was the reference centre, certainly geographically closest to St George's. To what extent was there any kind of relationship between St George's Haemophilia Centre and St Thomas's Haemophilia Centre in the late 70s or in the course of the 80s?
When I started out, Professor Flute had, I think, a good relationship with Professor Isley Ingram, who had started the St Thomas's Haemophilia Centre and was a extremely multi-talented and senior individual. And Isley Ingram ran this thing called the Coagulation Club.
Hemostasis Club?
Hemostasis Club, that's right, sorry. He ran this thing called the Hemostasis Club, which was like on the British model of genteel academia, where enthusiasts for a certain subject would gather and hear presentations and chat and discuss the presentations and generally form a community. So I, as a registrar, I was encouraged by Professor Flute to attend the Hemostasis Club if I could, to get a flavour of this, and I did. Not that I comprehended much of the presentations. So it was all good in that. And then when Geoffrey Savage took over from Professor Isley Ingram, there was definitely a change. As again, this was only by kind of hearsay and from Professor Flute himself. I think he found Professor Savage somewhat rebarbative colleague, not afraid in any way to criticize the actions of a smaller centre or people he considered to be less expert in the treatment of haemophilia. And at one early stage, I think something must have been said that offended Professor Flute deeply, and so he came and said, "Oh, as a new chap at St Thomas's, very difficult man. So there was just a feeling that there was a possible conflict there. Now, in myself as a Haemophilia Centre Director, I find that if I needed advice on a particularly difficult or a case that wasn't going quite as planned, I would ring Jeff Savage at St Thomas's, and he was always very helpful. And on a personal level, he was always perfectly helpful. But one knew at the same time that he was attempting to take over the care of patients from the smaller centres in the region. And he did this out of principled stance that they would get better care at St Thomas's, which of course, when I eventually came to St Thomas's, I saw was possibly the case. Certainly before we had a haemophilia nurse, he had haemophilia nurses, and they were very good. And there's absolutely no doubt that the care of an individual with haemophilia in a centre is the role of the haemophilia nurse is absolutely critical. It's the reason why a centre exists. I don't think now that I would say that anybody could have a haemophilia centre in a meaningful term of the word without a haemophilia nurse to look after the patients, because the consultant who will have many other concerns is a very variable presence and focus, whereas a haemophilia nurse will look after the patient. So in that way, he was completely right. Completely right.
Some witnesses who've provided statements to the inquiry have described being treated at both St George's and St Thomas's. I mean, did that happen during this period? Might there be a patient who might be treated at St George's for one purpose and then be treated at St Thomas's?
Yes, at St George's there were of course truly excellent orthopaedic surgeons, but they were excellent enough to recognise that operating on a haemophilia joint, particularly one that had undergone substantial damage through chronic haemophilic arthropathy over the years, where there were forms of contraction and synovial hypertrophy that orthopaedic surgeons in the general practice would almost never see, and very difficult to operate on those joints, to do a joint replacement. There was, on the other hand, a consultant orthopaedic surgeon at St Thomas's with experience of many such operations. And therefore, the most likely cause for a patient to be under joint care at the centre was that I had referred them on to Jeff Savage and his orthopaedic surgeon for joint replacement treatment. So that was the main cause.
Just going to look at a couple of annual returns for St George's with you, just to see what we can see from it in terms of numbers of patients treated in two particular years and products used. The first is for 1976, the second for 1983. Those are the two returns we have for that period. Shomik, could we have HCDO 5024_004, please? And that's just a covering letter from Professor Flute to Miss Spooner at Oxford. But if we can go to the next page, please, Shomik. We can see here, this is the annual return for 1976, St George's Hospital, Professor Flute, number of haemophilic patients treated during the year 25, total number of Christmas disease patients treated during the year 5, and then we can see in terms of the products being used, cryoprecipitate and NHS factor 8 concentrate in that year, and we have the figures there. So a predominantly cryoprecipitate usage, it would seem, and then NHS factor 9 further down for the Christmas disease patients.
Yes.
And then if we go to the next page, please, Shomik.
I mean, that's the first time I've ever seen that one. That's very interesting. That was, of course, before I was a haematologist even.
And then we'll go to the next page. And we can see number of patients with von Willebrand's disease treated during the year 3 and the treatment there, cryoprecipitate. So that's just to give us such information as we have from 1976. The next return we have, Dr. Bevan, is 1983, So we'll look at that next, please. HCDO 40/143_003, please. We go to the next page. So we can see here, Dr. Bevan, again, this is the annual return for 83, completed by Professor Flute. Total number of Haemophilia A patients treated during the year 31, von Willebrand's disease patients treated during the year 4. And then if we look at the rest of the document, please show me. No, the whole of the page, please. Thank you. So we can see there now the amount of cryoprecipitate identified significantly less than 1976, and it would appear used for hospital inpatients. And then we have for NHS factor 8 concentrate, 62,770 units in hospital, 71,950 units for home treatment. And then we can see the use of ARMA factor 8 concentrate, 270,755 and 309,680 respectively for hospital and home treatment. A small amount of CoA being used, Cutter's CoA, and then we can see on the right-hand side cryoprecipitate being used for the treatment of von Willebrand's disease patients in hospital. And then if we just go to the next page, please, Seamus.
Just before you do, the cryoprecipitate, there's a note there in handwriting based on 50 units per pack. If we were to draw a comparison between this and the 1976 return, which is 5024_004, let's just have a look at that.
Yeah, HCGO 5024_004.
What I'm going to ask is there
Second
a like-for-like comparison? Let's have a look at the figure. There we'd only see the number of factor 8 units, which is, I think, it's what we've come across before, roughly 70 units of activity per one bottle. But are we comparing like with like, looking at this and going back to the 1983 return?
Probably. I mean, one of the uncertainties about cryoprecipitate is always exactly how many units are in a bag. A bag is a single bag of cryoprecipitate is the cryoprecipitate from a single unit of donor blood, and then a dose of cryoprecipitate would be assembled from say 10, sometimes a few more bags. For adults, perhaps up to 20 bags, and that would fit with 50 units per bag. And 50 units per bag was probably the standard used by the National Blood Transfusion Service at that time. So they would expect their bags, on testing, to contain within plus or minus a couple of standard deviations of 50 units. So if a bag only contained 30 units, they wouldn't issue it. So they had a standard. So we probably took that standard from them of 50 units per bag.
Thank you.
I mean, yeah, sorry. So I think they are comparing like with like.
So if we just go back then to the 83 return, or forward to the 83 return, HCDO 40/143_003, please, Seamus.
Yeah.
And we can see here perhaps the most significant change from 1976 is the use of significant quantities of commercial concentrate?
Oh, vastly. And of course, this was the pattern all across the haemophilia world. I mean, we may even, St George's may even have been slightly slow to replace cryoprecipitate with concentrate. But the massive increase in concentrate, and basically looking at that, haemophilia cryoprecipitate essentially ceasing to be used, because 200 units is less than a single dose.
And then if we just go to the next page of this document, Seamus, please, just complete the picture for 83 as we have a full return for that year. This is patients with antibodies, haemophilia A patients with factor VIII antibodies, one patient treated during the year, and we can see that's with both ARMA factor VIII and fiber. And then if we go to the next page, please, Seamus, we have the figures for the Hemophilia B patients treated during that year. We can see there are 3 patients with Hemophilia B treated during that year, and exclusively NHS factor IX concentrate, both at hospital and for home treatment. Now we can take the document down. Thank you, Seamus. We're going to come on in a moment to ask you in a little more detail about the approach to treatment and the kind of decisions that were taken as to which products to use. First of all, however, is this right, that in the period up until the time you took over as director in the summer of 1985, decisions as to which treatments to use and which particular products to use were the responsibility of Professor Flute?
Yes, 100%.
And your statement would suggest that you had little involvement in the process, in part because you were in training and also because you were rotating around a number of different hospitals.
That's correct. I'd only just seen my first bottle of factor VIII ever, just before starting in 1976 at St George's. I had essentially no idea of the commercial world of factor VIII purchase. So no, he did all that.
Now, in that period of time, late 70s and the first half of the 80s, what was the home treatment, home therapy programme at St George's? I think you referred to it as having been piecemeal when you started. What can you recall about it?
Well, I think it had grown, and I think that was shown by the 1983 returns, that in terms of the usage of factor VIII concentrate, that it was sort of fairly evenly balanced between home treatment and on-demand treatment in hospital. I mean, it was acknowledged that home treatment was a far better model for treating haemophilia because the required doses of factor were given earlier. So there are 2 forms of prophylaxis. One is, there are 2 forms of home treatment. It obviously is a model for prophylactic treatment. But at the time that I started, prophylactic treatment was used in some patients who were mostly in children or young people, but was still a minority thing. So most people on home therapy kept it in order to administer themselves doses in the event of a bleed. They perceived they were having a bleed, so that's called on-demand. So the majority of the home treatment was for on-demand. To give home treatment, you needed a patient or a relative, in some cases it was their parents that injected them, who was trained in venipuncture and intravenous administration. So some people were never really interested in it because they didn't feel able to do that. They weren't able to do that, or their veins did not allow it. So that was, in a sense, it was piecemeal. It wasn't for, not everybody wanted it, and we could certainly only afford a certain amount of it. At the moment you start giving home treatment, your treatment requirements go up. The reason being that, of course, patients don't like going to hospital having intravenous injections, and they would surely delay going until it was absolutely imperative, which means the bleed is already reached a certain point, which has probably done damage to the joint, which will become permanent. Whereas with home treatment, the patient, there aren't the barriers of traveling and waiting in hospital. The patient can administer the product as soon as they get, sometimes quite early, feelings that come with an incipient bleed in the joint. So an experienced patient will recognize the very earliest features of an oncoming bleed in the joint and be able to treat when perhaps the volume of blood in the joint is still very low. So that's why home treatment is absolutely a better form of treatment.
Now, you've told us in your statement your understanding of Professor Flute's approach to treatment, and I'm going to go through different categories of patient. You say in your statement you were aware of Professor Flute's decisions only insofar as he explained them to junior staff. To what extent did he explain his thinking to staff? You obviously got a broad idea of what products he generally used for different types of patients, but to what extent did you know why?
He would occasionally share parts of his decision-making. Professor Flute was an extremely genial and pleasant man, but he'd come from a tradition, almost like a semi-military tradition. In fact, I believe he was still a colonel in the territorial army, responsible for blood transfusion within the territorial army. And there was something of the senior officer about him, in that we would let, on a need-to-know basis, in terms of our training or the running of the department, he would let us know. But we were not privy to many of the reasons for his decisions. He did, however, as I've said, promote the idea that, in his opinion, it was not a good idea to have a multitude of providers, which I think you can see from the returns, that once he settled on a once he settled on a supplier, he would stick with that supplier, in that case Armour. So I have read other evidence which suggests that people felt that they shouldn't put all your eggs in one basket, that you might run out. He didn't work according to that principle. His principle was he wanted very much all his eggs in one basket, because I don't know, I can't say what his reasons for this were. They could have just been convenience, i.e. you only have to deal with one set of commercial operatives from the company. But anyway, that was very much his view. He told us about that, and it's expressed in the annual returns.
Now, Haemophilia B patients were, as I understand your statement and from your recollection, consistently treated with NHS factor IX concentrate, which you recall being the Oxford concentrate prepared at Dr. Bidwell's laboratory.
Yes, Dr. Bidwell, amazing. I mean, a completely self-sufficient production of factor IX. Of course, you don't need as many units of factor IX nationally, but that was, and what's more, she managed to keep up the supply for what was required. So yes, I'm glad to see that we were restricted to that. And then when the concentrate came into the national NHS, to the BPL factor IX, that also, we didn't need much in the way of commercial factor IX.
Now, severe haemophiliacs, you've said in your statement that, as far as you can recall, Professor Flute's preference was to treat children and younger adults who had severe Hemophilia A with the NHS Elstree product, if it was available, because he considered it less likely to transmit non-A, non-B hepatitis. Is that correct?
That was my understanding at the time, yes. I mean, he was perfectly aware of the occurrence of what I think he probably still called serum hepatitis until late 70s, and made that decision, yes.
Can you recall any discussions with Professor Flute about why he considered the Elstree concentrate less likely to transmit non-A, non-B hepatitis? Were there discussions about relative pool sizes or donor attributes, for example?
I'm afraid I do not recall any specific mention of that issue.
Now, your statement says that unfortunately there was never enough Elstree product, so older adults were usually given commercial concentrate, the ARMA factor 8, as we see reflected in the returns, and that in fact younger patients would also end up receiving ARMA factor 8 because it was a regular event that there was insufficient Elstree product. Is that right?
Yes, yes, that's true.
And did children also end up receiving ARMA because there wasn't enough BPL product available?
I'm afraid I can't say with any certainty, but I would have thought it was inevitable.
Can you recall anything, again, I'm talking really about the period in the late 70s and the first half of the 80s here before you took over as director, but can you recall anything about what the arrangements were for obtaining the Elstree product or the ARMA product? Was it all done via the blood transfusion centre in Tooting, or was it done directly with BPL or the pharmaceutical company?
The commercial factor 8 was purchased from the pharmaceutical companies with direct contracts. The BPL product was accessed through the National Blood Transfusion Service. Now, here my knowledge is not complete, but my understanding was that during the early years, it was managed through the BPL. It was essentially free product, although nothing from BPL is truly free. But the fact is that it was the region, right, so the Southwest Thames NBTS Centre was also at Tooting on the St George's site. And the amount of BPL product it received to pass to the haemophilia centres in the region was linked to the amount of plasma the NBTS Tooting contributed towards the national plasma, the BPL product pools. Whether that or actual total product production by BPL was the limiting factor on our supplies, I think probably their overall production was more a limiting factor than any particular shortfall of the NBTS centre. But yes, that was, if you like, there was a double constraint on the amount of BPL product that was available to us in that regard.
Dr. Winter told us about his experience of particular difficulties obtaining sufficient quantities of NHS product from Tooting. And he identified a particular problem being that the Tooting Regional Transfusion Centre covered two very large regional health authority areas, the South East Thames and the South West Thames. And his evidence described a service under pressure, unable to meet demand. Is that something you have any recollection of yourself?
As far as I recall, that was true, yes. That was true. Yeah, very much so. In addition, of course, they had within their catchment area the Royal Marsden Hospital, which was a very large consumer of blood products such as platelet transfusions. So yes, I think they were always short. They were never replete.
Now, going back to the treatment policies towards severe haemophiliacs, those with Hemophilia A, you describe in your statement that having been, when you arrived, a small number of individuals on cryoprecipitate. And you say that Professor Flute had, I'm paraphrasing your statement here, been content for that to be the case because it was cheaper to treat with cryoprecipitate than it was with concentrate.
Well, essentially, cryoprecipitate was free at point of use. I mean, obviously, in the NHS structure as a whole, it wasn't free, but to the end user, it was free. Whereas from the very start, the commercial concentrate was regarded, certainly by other aspects of the hospital, as one of the most expensive therapeutic products that on the entire field. So, yes, it was much more a hit on one's budgets to buy the commercial factor 8.
Do you know what, if anything, patients were told by Professor Flute about the comparative risks of concentrate versus cryoprecipitate or NHS concentrate versus commercial concentrate?
In strict terms, no. However, Professor Flute did communicate to us that he told everyone that was going to receive concentrate that they would be likely to get a brief period where their liver function was affected, that there was a form of hepatitis which was almost inevitable, as it was, very soon after first exposure to commercial pooled product. And he would tell them about this, but he would tell them about it and us in a reassuring way. Everybody goes through this. It doesn't seem to cause any problem. People don't get very sick with it. Sometimes you don't even have jaundice, sort of thing. So they were informed, but I would say that neither Professor Flute nor the patients were what we now call fully informed about that, validly informed.
And I'll come on to ask you in a little while about hepatitis in a little more detail. In terms of patients with mild haemophilia, what can you recall being the approach to their treatment? Again, I'm talking in the period under Professor Flute's directorship up until 1985.
Well, by mild haemophilia, you mean the technical definition is anyone with greater than 5%, if you like, of residual factor VIII. But it also goes up to people who are on the edge of normal. In fact, may probably be normal, just a few points off. I think his position was they didn't need treatment at all. When desmopressin came in, which was about 1982-3, I think, then he commenced to use it, with some enthusiasm, because he saw it as a way, firstly, in terms of treating individuals with von Willebrand's disease. It covered a lot of the conditions that you'd need to treat them for. And this was certainly true of mild haemophilia as well. So we were definitely using desmopressin when I was a senior registrar. In fact, my colleague and I reported a case of an elderly gentleman who actually died after receiving desmopressin from a myocardial infarction, and this was published and got us a bit of criticism from Minucci for exaggerating it. But that was a highly unusual, and after that we learned to be cautious with certain types of individual giving them desmopressin.
We've heard from other clinicians in some centres that they were able to use desmopressin from the late 70s. Is your recollection is that it was a little later for St.
All
George's?
I can know is that during my period as a senior registrar, it was in full use at St. George's. So when he started it, I'm afraid I can't say.
If, for whatever reason, desmopressin was not available or not suitable for a patient with mild haemophilia, and leaving aside the requirements potentially for major surgery, what was the next product of choice for a mild haemophiliac? Was it cryoprecipitate or was it concentrate?
Well, by definition, if you were going to treat mild haemophilia, it would usually be for a surgical operation. A surgical operation obviously depends on the nature of the operation, but if it's major surgery, you need to maintain a factor VIII around 100%, maybe for a week, to allow the initial wound healing happen. It's very difficult to achieve that with desmopressin, because after a second, desmopressin raises the von Willebrand factor and factor VIII for about 24 hours. If you need it longer than that, a second dose of desmopressin is often less effective than the first. And after a second dose, you're beginning to run into the other problem of desmopressin, which is that it is an analog of a pituitary hormone which conserves sodium, and so people get, which conserves water, and therefore people can get very dilute plasma and low sodiums, which can be fatal. So you can't maintain someone at 100% of factor VIII for a week with desmopressin. So you have to use some other form. I think it would be very rare, but that in the event of major surgery, someone with mild haemophilia would usually receive BPL factor. I would think that would be what would be done. He would classify them as a rare user and therefore do everything he could to give them entirely BPL product.
Now, what about patients with moderate Haemophilia A? What was the approach to treating them?
Well, people with moderate Hemophilia A are very heterogeneous, so to have just 1.5%, if you like, no essential difference to a severe haemophilia, certainly in terms of bleeding around surgery. You may get less spontaneous bleeding and not need prophylaxis and not need home therapy. But if you have a surgery, you will be in exactly the same position as someone with severe haemophilia. And I think internationally it's been shown where surveys have been done that in general over a lifetime, people with moderate haemophilia end up having in the same ballpark of treatments with factor. So I think it was more likely that if in the case of surgery, they would receive a factor 8 concentrate. And again, I imagine that he would attempt to use BPL in those patients. But I can't, knowing the shortage of BPL, I'm pretty sure that there might have been exposure to commercial concentrate in that group.
Now, you describe in your statement drawbacks of cryoprecipitate, and you've put it this way in your statement: the majority of patients receiving cryoprecipitate would, after cumulative exposures, experience severe febrile transfusion reactions. Now, Dr. Bevan, we've heard other clinicians describe reactions to cryoprecipitate, but I don't think we've heard it put quite as strongly as that the majority of patients would respond in that way. Bearing in mind there were, I think, only 5 or 6 patients receiving cryoprecipitate when you arrived, and that number diminished down to, I think you described 1 or 2 and then none in your statement. What's the factual basis for your understanding that the majority of patients would experience such reactions?
Right. We only had 8 patients, so a majority would just be 3 or 4 of them, I think. So as far as I remember, it was widespread, but my memory is such that obviously such reactions were very striking and much more likely to stick in my memory than, say, the person who didn't have them. And then, again, this is probably quite a widespread perception. With a small number of patients, the people who needed cryoprecipitate on a regular basis, who were severe hemophiliacs, who had no other product, or decided to have no other product, they were frequent attenders. So it may be the majority of attendances, I remember, that this was an issue. Now, maybe not everyone got the most severe form. Maybe on many occasions, you could suppress the symptoms of the reaction with hydrocortisone and Piriton. But the ones that stuck in my memory, and therefore, after so many years, come to dominate my entire picture, are 2 individuals, fully grown adults, one of them almost middle-aged, and sitting suffering in the bed with the bed shaking and rattling because it was an old-fashioned steel-framed bed with the power of this Rigors they were getting. And that was despite going up to the limit of safe treatment with Piriton and hydrocortisone. So it was it was a very prominent thing in my memory.
The reactions that you describe as being, in the ones that certainly stick in your memory, unpleasant reactions, were they nonetheless temporary reactions?
They were temporary, although when the body has a reaction like that, there is a kind of a brief cytokine storm. So there is an after effect that may last for several hours. For a start, the amount of Piriton I get will almost certainly have sedated them and made it impossible for them to drive home, for example, or so they would need to rest up for a couple of hours after this, a cup of tea. So yes, they would recover, but I think that for one of those patients, definitely, he developed an almost phobic response in that he would delay coming until the bleed was really quite advanced. So, yeah, that's as I remember cryoprecipitate.
Now, cryoprecipitate wasn't, I think, from your statement, used for home therapy at all at St George's.
No.
Were you aware at the time that it was used for home therapy, or had been used for home therapy, with apparent success in some centres? Royal Free in Birmingham are two that the inquiry is aware of.
Well, as a haemophilia director I perhaps wasn't aware of the practice in the UK. I was aware that in America, where many homes had domestic freezers, that cryoprecipitate could be used. I still think that it would pose considerable practical difficulties for the patient to administer cryoprecipitate. First of all, the business of subsampling bags. This is in the British system. So I think part of the American facility of using cryoprecipitate in home therapy was that their formulation of cryoprecipitate was somewhat different. They had, for example, freeze-dried cryoprecipitate. They had liquid cryoprecipitate. They had various forms which were, if you like, more convenient to use. The British form, where you needed to subsample to get a dose from, so for example, you've seen that the broad number of units in a single bag of cryoprecipitate was 50. Therefore, a dose for an adult, it has to be maybe 1,000 to 2,000 units. So you have to give 20 or more bags, and subsampling these into a single bag is fine when you can infuse it through a drip in hospital. But setting up drips on yourself is not a straightforward thing. So the home user would have to draw it up into a very large barreled syringe, like a 50 ml syringe, and give it in several doses. I mean, very, very inconvenient and complex. And we know that, so I'm interested that some centres found that practicable. I remember reading about Catherine Dormandy's approach, that she used to transport the cryo, and even if the patients did not have home freezers, they used to keep it with solid carbon dioxide card ice. I mean, a hazardous substance likely to administer serious cold burns if you mishandle it. So complex and with many pitfalls, but nonetheless, yeah, I can see they did it. I didn't know at the time they were doing it.
And is this correct? Please say if it's not, that in terms of the treatment of children at St George's during again, I'm talking about the period up until 1985, cryoprecipitate was not, as far as you can recall, used for children at all?
No, because all those problems about volume and reactions, if you like, more prominent, more prohibitory in children. And I think also with children, as quite rightly, you have a huge input from the parents, and if the parents given the option of concentrate versus cryo would always go for them, because the reduced volume of injection down to about 30 mils with the early concentrates, it was an enormous step, because now an injection could be given through establishing an intravenous access in a child is difficult, can be difficult, and is, you want to use it and get out of there as soon as possible. You don't want to trust to an intravenous cannula being able to sit in position for perhaps, 20 minutes or half an hour while you slowly administer viscous cryo. So there were all sorts of reasons why the children got concentrate.
You've said in your statement parents wouldn't have allowed children to have cryoprecipitate, and one can quite understand the convenience of concentrate over cryoprecipitate for a parent, but would you accept that a parent's choice in those circumstances might depend upon what they were told about relative risks, and we'll come on to talk about the risks of AIDS a little later, Dr. Bevan, but a parent might wish to opt for a safe but inconvenient product over a riskier but more convenient one.
Yes, I can't say what parents were told about that, either by Professor Flute or by their pediatric consultant. Yes, I mean, I think here, at that time, the only risk we knew about was non-A, non-B hepatitis. We thought that the Hep B situation was covered by testing. And accordingly, cryoprecipitate was not free from risk of transmitting non-A, non-B hepatitis. In fact, you may see later when it comes on to the Hep C look back at St. George's, my main two patients were, one that had received NHS cryoprecipitate entirely during treatment for a condition called TTP. Another one was a patient who received platelet transfusions from the BTS. So cryoprecipitate could not be considered free from non-A, non-B. Yes, because of the pool size, it was less. But again, you have to consider that if for a dose of cryo you have to subsample donations of cryoprecipitate from 10 bags, that's 10 donors, it builds up. And over a year, someone entirely on cryoprecipitate would experience exposure to the plasma of perhaps 100 donors. So non-A, non-B was in the bridge population, in the donor population, and being transmitted by these products. Much lower risk, but the risk was not zero.
And in relation to those patients, the handful of patients who'd remained on cryoprecipitate, you've said in your statement they negotiated a change to concentrate within a year or two, or Professor Flute had negotiated a change to concentrate within a year or two of your arrival. Do you know what those patients were told about relative risks of cryoprecipitate versus concentrate?
No, I don't know.
So I know the time, and I'm going to move to a slightly different topic, so perhaps this might be a convenient moment for a break.
Yes, we'll take a break. We normally have a half-hour break in the morning to allow people at home watching and you giving evidence to have a cup of coffee or whatever, and that's what we do. What you mustn't do, you may have heard me say this on other occasions to other witnesses, I don't know, you mustn't discuss your evidence, either the evidence you have given or that which you're likely to give, you think, with anyone, whoever they are. It includes your daughter, if she was interested. But you can talk about anything else you like. I look forward to seeing you back at, shall we say, 11:45.
11:45, thank you very much. No, I won't talk to anybody.